Firstly, a very warm welcome to Imperial College London. This is the first of a series of inaugural lectures for the beginning of the new year. And I think, as many of you can imagine, it gives me enormous personal pleasure to be here introducing Professor Sheena McCormack for her inaugural lecture. Sheena is a product of Cheltenham Ladies College, where I understand she was head girl, perhaps I should be head lady, for 1 week. Still counts. She was then a medical student at Charing Cross Hospital Medical School, now part of Imperial College, where she was president of the Students' Union and winner of the MacLeod Cup in 1981. I still don't know what the MacLeod Cup was, but we may find out during the course of the evening. Sheena then trained in general medicine and in genitourinary medicine, mostly across West London, and then at an extraordinary early age was appointed to the position of consultant physician GUM in the West Country at Royal Devon and Exeter, I think in 1991. And then worked as a consultant physician down there, and also I think part-time at the Charing Cross in the early 90s, until 1994, when a sort of road to Damascus conversion occurred. And Sheena decided that she really wanted to consider a more research-orientated career. And at that point, it's when I first came to know Sheena and was being associated with her career since that time. And rather than dwell on what comes next, which is going to be the subject, I think, of Sheena's inaugural lecture, just for me to say what an enormous pleasure it's been for me personally to work with Sheena over so many years. She's been a spectacular attender to detail in every way I haven't been, and it's been a glorious relationship to be able to work in research together over a number of continents in a number of areas all around the prevention of HIV and in a most productive way. So without further ado, I'm going to welcome Professor McCormack to give her inaugural lecture. The inaugural lecture is the most extraordinary affair. It's the only time in most academics' lives that they get to give a lecture to their families. And this is particularly the case here, as I can see quite a number of family members and friends here, and a very warm welcome from the college to you all. So without further ado, Professor McCormack.
That one. Okay, so I think I've got the mic on. Everything good for sound? Thank you so much, everybody, for coming. I really feel the warmth and support from you all on this occasion. As Jonathan says, it is a very nerve-wracking one. I am rather disappointed he doesn't remember sitting next to me at dinner in 1985 in Plymouth when he came down to give the lecture. But not to worry, we won't dwell on that. So I thought I have taken advice from my family, shall we say, in terms of preparing this lecture, because some aspects of HIV today, gone tomorrow, and the biomedical prevention of HIV are really quite technical. And I'm going to start, once we go over the timeline of HIV, moving on to the vaccines. That's probably the most biologically technical of all. But bear with me, because we will be moving on to the more behavioural aspects, and I'm quite sure you're all going to be with me for that. So the timeline, as I say, the first time I heard about this was in 1985 when Jonathan, who was a research fellow, I think, at Imperial, then came down to give a lecture in Plymouth. I was a junior doctor down there at the time. But this is an epidemic that began way before 1981, but we're going to start in 81 when the first cases were reported. By the end of that year, there were 270 cases reported, and nearly half of them had died. But it wasn't that long after that the virus was identified. That's really quite a short time in terms of other infectious diseases that have gone beforehand. And soon after identifying the virus, we had a test that meant we could see who had been exposed to the virus. And in an even more remarkably short time, there was a drug that had been approved. Now, I guess what's remarkable about that is, and I think now about drug development, it feels like it's 10 or 20 years, you know, even to get drugs, and certainly for vaccines, it's a very long haul developing any of these things. But because the virus had been identified, because there were tests, it was possible to take drugs off the shelf and test them. So AZT was approved. 1990, which is the year that my son Alec was born, Ryan White, who was a haemophiliac in the States, he had caught HIV through blood products, and he died in that year. Now, he was refused entry to schools in the 1980s, and that launched a campaign to try and counter the prejudice and the stigma that was arising around HIV and AIDS. That same year, Jonathan Mann, who was head of the WHO AIDS program, resigned because of the lack of effort on the part of the United Nations and governments to combat the epidemic, to make any effort to combat the epidemic, because the science, really a lot was known about the science at that time. 1992, which was the year my daughter Sydney was born, AIDS was the top cause of death in US men aged 25 to 44. Then in 93, at our own trial, the MRC Clinical Trials Unit, together with the French Agency for HIV Research, reported on the Concord study that there was no benefit of this drug AZT in early HIV. But by this time, the prejudice, the stigma had really risen, and finally at last Hollywood and the artists threw themselves behind trying to do something about that. And those who were around at the time may remember Tom Hanks' film Philadelphia, and Angels of America, the play that won the Tony and the Pulitzer. So by 96, that's our key turning point, really, scientifically for the epidemic, because that is when triple therapy, using 3 drugs together, something we were already doing for TB, was shown to be effective in controlling HIV. Controlling virus, I'm not sure really then that we had the confidence, if I look back at that time, if we had the confidence to know it was going to be quite as good as it's turned out to be. But certainly there was cautious optimism. It was still recognized that if we wanted to control the epidemic, we were going to need a vaccine. And the International AIDS Vaccine Initiative was formed that same year, 96. So at the end of the decade, 99, HIV/AIDS is now the top cause of death in Africa. A vaccine trial finally has started with a recombinant protein. Very mixed thinking about that trial, whether it was worth doing or not. But in many ways, until you go to the field, you cannot be sure. So I talked a little bit about the stigma and the prejudice. Of course, once people realized about the epidemic and the kind of the only tool we had at the beginning, of course, was behavioral change. There were various campaigns to try and do something about this. And this is probably one of the most extreme campaigns to promote behavior change. It was an Australian video, and I don't know how well it will pick out I guess you can see the skull here, the Grim Reaper. But there's this it's a bowling alley, and people are dropped down, and they're a very heterogeneous group, so all races, genders, and sexual orientations. And he runs a bowl down, and it knocks out all of them except for this mother and the child. But he's not finished there, and he puts another bowl down, and the mother and child are dust. It was that sort of thing that, on the one hand, led to dramatic reductions in syphilis and gonorrhea, but on the other hand, fueled the prejudice and stigma and actually inhibited people in some ways from going forward to be tested. So then we move on to, now finally we move on to a really different period of HIV. We've had the triple therapy in 96. In 2000, UNAIDS, WHO, launched an initiative to reduce the price of drugs, all with the view to trying to tackle where the global burden of the epidemic is, which is in more resource-limited countries. 2002, the global funds launched to fight AIDS, TB, and malaria. And then the first microbicide phase 3 trial, the final stage of testing a drug, reports no benefit with naloxone 9, the licensed spermicide, which has been formulated in a vaginal gel, and possibly even because there was a statistically significant increase in infections in the women using N9, possible harm. PEPFAR's launched, the President's Emergency Fund, and International Partnership for Microbicide, another not-for-profit like IAVI, are formed. The VaxGen trial I mentioned at the end of the last slide now reports, and there's no benefit seen from a protein vaccine alone. But already, not long after, 2 years later, we're on to the next second vaccine strategy, looking at a cellular approach. And I'm going to try and explain this shortly. cellular responses goes into this final stage of testing, not quite a fully powered trial, but the final stage of testing. They are collecting HIV endpoints in people. And then STEP reports no benefit and actually also cannot exclude harm. There are more infections in the vaccine group compared to the placebo. And then the last thing I wanted to tell you before we move off the timeline was in 2011, the HPTN-052 trial reports confirming that treating the positive partner to a degree where their viral load is undetectable significantly, really significantly, almost eliminates the transmission of HIV. We already knew this from observational studies, but this was a randomized trial where the positive partners were either given, they were randomized to have treatment straight away or to get it at the stage at which their immune system indicated they needed it. And it was a 96% reduction. So very exciting. But in our own epidemic in the UK, which is a fairly targeted epidemic in men who have sex with men, so you'll see that acronym coming up again, MSM, gay, and other men who have sex with men. So perhaps we should look at the blue line. Let's get the pointer here, if I can. Yeah, so the blue line, because you may not see this at the back, that's 1981 where it starts, and it's taking you through to 2009. But you can see this big increase in the early 80s, then it stabilizes out and then starts to pick up again. And actually, in the last 3 years, we've had more infections in each of those 3 years than have ever been reported in any of the other years. And yet here in the UK, we have universal access to treatment. It's free, and no referral is required. So I think we certainly feel here that treatment alone is not going to eradicate HIV, and it's why we're going to need prevention. So, but what about those Australians, though? So they really moved on in the last decade. So we've moved from the Grim Reaper to the Glam Reaper. And this is now a slightly less heterogeneous group. Their epidemic is also fairly focused in MSM, and safe sex is the message. So still behaviour change. So that's 2007, but things have changed since then, and I hope to show you a bit more of that. They've just released the new data, so I'm very sorry to be, they could have updated these 2 days ago, but the principle is there. And if you look at the number of new infections in 2012, it's 2.3 million. So a very slight reduction again. It is just beginning to go down. And over that last decade, with those efforts made, ART has rolled out to Africa. Some countries are meeting 85% of their need, like Zambia, but most others are meeting 50% at best. And certainly we still know in the trials that are run from the MRC Clinical Trials Unit, people are coming in with really quite shattered immune systems, very late stage HIV, and they've not been able to get treatment. So the burden, I'm sure probably all of you know, is in sub-Saharan Africa. So of that 34 odd million, that's pretty similar figure now, 23.5 million are in sub-Saharan Africa. And what about the money and how the money tracks this? So this graph is showing the share of care and treatment expenditure. So in the red countries, the countries that are marked in red, 75 to 100% of their funding for HIV depends on international aid. In the green countries, then 0 to 24% does. So you can see in South America, in Russia, in South Africa, they're really doing pretty well to support their own HIV care and treatment programs. But in many other countries, they are totally dependent on that international aid. Now, the grey countries are where no data are available, but at the conference I've been at for the last 2 days, I understand that China is also in that 0 to 24% bracket. So they're also meeting their treatment aim. So Jonathan mentioned about it was slightly serendipitous, my change. It was somewhat for family reasons that I needed to come back to London in 1993, and I went to see Jonathan and to see if he might have a job for me in research. I thought it would be a good idea to do some research because I hadn't done any formal research during my clinical training, because really at that stage the urgency was to do the clinical work with all of the patients with HIV coming through. And Jonathan said, well, I haven't got a job, but why don't you go and see Janet Derbyshire? at what is now the MRC Clinical Trials Unit. So I met Janet, and then I met Abdul Babika, the statistician, had my interview, and I started in January 94 as the vaccine trial coordinator. So this is where the biology comes in, because we're going to have to start with the vaccines. So what I think I need you to understand here is that that green football in the middle, which has got HIV in it, has got little sort of blue bobbles on it. Those are envelope proteins on HIV. And then if you chop the HIV in two, the mature HIV, you see here the core proteins for HIV. So we've got core proteins, we've got envelope proteins, and that's what we want to mimic the genetic code of in order to elicit a response in healthy volunteers. Now, all of those stop signs are really a bit more related to the drugs that we use. So you want, and they're important because we're using drugs in HIV-negative people. So this will come up later. So since the slide's not coming again, you can stop HIV attaching to the host cell. The whole purple blob over here is the host cell. You can stop it fusing with the cell membrane, or you can interfere with the enzymes that it needs in order to replicate its lifestyle and be released again. But for the vaccines, it's the blue bobbles that are the envelope proteins and the core proteins here that we're trying to do stuff with. And what is it that we're trying to do? Well, we're trying to make antibodies, proteins, to neutralize those envelope proteins, to neutralize the HIV, or we're trying to make a cellular response that's able to then tackle the cells, punch holes in the membranes of infected cells and destroy those cells. So, neutralizing antibodies, blue bobble envelopes, and cellular responses killing, which tend to be to core. And we need to stimulate memory cells for both of these aspects of the immune system. Now, why is designing an HIV vaccine so difficult? There are probably many reasons, but the one I think that stands out above all is the fact that we don't really have a natural example of protection against HIV. So the first trial that I went off to the MRC to do was MRC V001, funded on an MRC grant. And we were looking for 30 healthy HIV volunteers. They had 3 immunizations over 6 months, and we were looking at a recombinant envelope protein. This was before we knew that the envelope protein strategy was not going to benefit people. But we were also looking at 2 novel adjuvants. So we were working with SmithKline Beecham Biologicals, who've become absorbed into GSK. And they had 2 new adjuvants, and we were comparing them to the standard adjuvant of alum. And what did we see? Well, we saw quite red arms. I don't know if you can see that red arm. And I'm pleased to say that they weren't painful. They weren't really painful. They were mildly irritating, kind of itchy, but they certainly were impressively red. But what we also saw here were these strikingly high levels of antibody. And that's measured over time. So here is the baseline before they've had any immunizations, then after 2, and then after the 3rd one. And this horizontal line here is a sort of level of antibody responses that people who've had HIV make. So you can't get a better immunogen than HIV itself. So we were really impressed, but they didn't neutralize. So they didn't quite tick that box for us. So maybe it was no surprise that that protein vaccine later was found not to show any benefit in protection. But there was some good news to come out of the trial, because the vaccine adjuvants have been licensed with the human papillomavirus vaccine. And so that's great. They've been modified, I'm pleased to say, so I don't believe you get red arms like that with this vaccine. They've been modified considerably, but basically that was the beginning of that development story for GSK. So then we moved on, like the rest of the world, to trying to stimulate that cellular killing response. That's what we'd become interested in. So we're saying, okay, we've done the proteins, it's in the final stage of testing, we'll try and see what we can do with the cellular response. And we worked with a Eurovac organisation in a European Commission-funded grant on a series of 3 trials. And in the first trial, we just gave 2 shots of a New York vaccinia vector. Now this is using a vaccinia, it's using a sort of using a vector, I don't think there is a better word, I don't think I can translate that one, to carry the DNA into the body. So the vector is quite a big thing, and therefore the body says, hello, hello, I can see this big thing, and actually inside the big thing is the HIV, and we'll get a response to the HIV as well. We hope, and we did. We saw 40% of people after 2 shots responded. But in this conglomerate, we also had an academic partner at the University of Regensburg, and they'd come up with the DNA that was in the vector, and it was felt at the time that giving the DNA first to prime the immune system might actually boost the response to the vector, and it did. So we randomly assigned people to get the DNA in the vector or to get the vector alone, and 96% of those who were DNA primed responded with their cells in the lab. The next question was whether 3 DNA primes could improve the responses to core, and the answer was yes. So I've been talking about the envelope protein before, if you remember, and then don't forget there's the core proteins too. So this DNA had envelope and core in it, but envelope tends to dominate the immune responses. And so that was the purpose of trying to give a third DNA. Could we get a better balance between core and envelope? And the answer was yes. So what was happening in the rest of the world at the time? There were 2 trials in the final stage of testing. This was one. Now this was unusual because RV144, sometimes referred to in the media as the Hiv vaccine trial, was actually combining 2 different immunogens. So they had the protein here, but they also had a canary pox vector, so a different sort of vector. I would say a lot less pokey than the one we were using, the New York Vaccinia, but it was still, it was a canary pox vector with some cellular responses. And they gave 4 shots of the canary pox and 2 shots of the protein with the last 2 shots of the canary pox. That was their timetable. And the other vaccine was called the STEP trial, and this was using the adenovirus vector, type 5. Adenovirus is kind of, like common cold and everything. And they used 3 of those, and I have to say that the cellular responses that were seen in the early trials were quite spectacular. So people were very excited about the prospect of this vaccine at least controlling the viral load, but probably also preventing infection. And then it closed early, and I mentioned this in the timeline. It closed early because that red line here, so you've got time over here, proportion over here, and a larger number of people who had the vaccine have actually acquired HIV compared to the placebo. So at the time, Jonathan and I were with Robin Shattuck and Andrew McMichael. We'd put a grant into the Wellcome Trust for the UK HIV Vaccine Consortium. We wanted to have our own material that was made to good manufacturing practice, in compliance with good manufacturing practice, and we wanted core support for data management and for the labs. And we wanted to build on that combination approach. So we wanted to use immunogens that would boost the cell responses to envelope and core and also produce functional antibodies, ideally neutralizing. And of course, we wanted mucosal responses because it's a sexually transmitted virus. The first place it's going to arrive is the mucosa. So we were very nervous because that other vaccine trial had closed, and we went along, and of course they said to us, what do you think? Is it ever possible that you could have a vaccine trial? And I remember we said, well, we know STEP's closed early. We know that RV144 have looked at the data. Their data monitoring committee, who look at the data by treatment group blind, will have looked at the data because it's a safety issue. As soon as another study that's similar closes for potential harm, the first thing that happens is all the other trials using the same drug or a similar approach will also look. So we knew they must have looked, and they carried on. So I think that's how we defended ourselves. We were right. We were right. In 2009, they reported protection with that combination approach, with a 31% reduction in HIV. But I wouldn't be a good clinical trialist if I didn't say it was only just significant, and the lower confidence bound was 1%. So we talk about the confidence interval, giving you a sense of where the truth lies. If it's as low as 1%, then actually really you've barely excluded chance as the explanation. But this invigorated the field, as you can imagine, and it endorsed our decision to pursue that combined approach. And it generated considerable renewed interest in a protein. And we happen to have a protein, because Robin had a recombinant GP140 protein, that it was funded by the Gates Foundation, and we were testing it. We tested it in the Mucovac 2 trial. Now, what I want to try and get across to you here in this trial, in these next 2 slides, is just how incredibly noble these healthy volunteers are. So we were looking for 36 women through St George's Hospital and through Uk Medical School. And they had either a low dose of the protein 3 times with an adjuvant, not unlike one of the ones that we were testing in that very first trial I spoke of. They had 3 of those, or a standard dose of 100, or they had it up the nose, an intranasal one with a different adjuvant, chitosan, or vaginally, but after an intramuscular prime. So they had the intramuscular prime and then 2 of these intravaginally. So pretty noble, but this is, I think, is even more noble. This is the sampling. So they had doses at week 0, 4, and 8, and they gave us serum. They gave us cells, which we need huge blood volumes of cells. But we also took samples from the cervix and the vagina to take cells from there, and we asked them to pop this little cup in and walk around for a couple of hours and then give us the cup with all their vaginal secretions. So noble or what? Those women were marvellous. And I'm sorry I can't share the results with you. They are going to be presented in a couple of weeks' time by Kath Cosgrove, the PI in Barcelona at the AIDS Vaccine Conference. But I was surprised, so that's always good. Now, moving on to the other vaccine teams, this is Professor Mohammed Bakari and his team in Muhimbili University in Dar in Tanzania. And this is Professor Leonard Maboko and his team in the Nimri Mbeya Center in Mbeya. And they have also been doing vaccine trials funded by the EDCTP. They've been working with partners at the Karolinska and the Swedish Institute of Communicable Disease with the DNA of theirs, and with the US Walter Reed Military Research Group with their MVA. So they've also been doing something quite similar to us, the 3 primes and the 2 boosts. But they've got quite a different sort of DNA. They've got a multiclade DNA. They've had long boosts between their MVA. And they've been focusing on methods to increase the efficiency of the DNA. So either giving it intradermally, they found that was better than intramuscular, a ZetaJet, which controls the amount you give intradermally, or electroporation, giving a little electric shock to increase the permeability of the cells. So we're still talking very noble volunteers here. So we saw an opportunity for the UK HIV Vaccine Consortium to come together with Tamavac, because they'd already completed this trial in Tamavac with the prime DNA and the MVA, and we wanted to come in with the adjuvanted protein. So that's been completed now in 40 volunteers, and their blood has been analysed locally in Mbeya and in Dar, and it's also gone with Agricola, who's a PhD student from MUHAS, all the way to the States, where she's been testing it for neutralization. Will we see more neutralization compared to that Thai trial? I don't know. Will we see more compared to Mucovac 2 when the adjuvanted protein was given alone? Well, I would expect we should. We really should. So that could be exciting, and possibly we'll see so much we should be planning to do efficacy testing. Who knows? So there are 2 enrolling trials at the moment of this DNA pox protein approach. One is going on at St Mary's in the Surrey Clinical Trial Centre, and that's a short schedule to see if we can accelerate the schedule. So giving you 3 DNAs and then giving the pox protein together or consecutively to see what happens there, see if it's safe and see if it's just as effective. And then in Tanzania and Mozambique, give the pox protein together compared to pox alone. So here's the team in Mozambique after their initiation training, and this is the electrocution equipment. So it's not that bad. I haven't actually seen it with the intradermal approach, which is the one with Tamavac, but I was there for the training for Qtavac, and it just gives a little muscle twitch, and it's not too bad. I'm looking at Bryn there because he actually experienced it. So that's giving it intramuscular. And the last thing I wanted to tell you about was our 3rd trial that's enrolling at the moment, Qtavac. This is an EC-funded study, and this is based on the premise that you want to stimulate the cells at the bottom of the hair shaft, because in that way we might actually end up presenting the immunogen to the immune system in such a way that we get more of those killing cells. So this is to try and see if we can get more killing cells. This is quite a technique. It involves putting a kind of super gluey thing on, and then it's like waxing with super glue, basically. And you take the hair shafts out, and then you put the vaccine on the exposed skin without the hair shafts, and then you put a plaster on and leave it for 24 hours. And you can't bath for 24 hours, but very exciting. We're looking forward to seeing what we'll see from this. And for those volunteers, we do have a registry and a site help make history. And I just want to really acknowledge the efforts that all the teams have made, but above all those volunteers. We couldn't do it without them, and we are eternally grateful. So back to 98, and we're moving on to the vaginal gels now. And I already see time is working against me, but I must introduce you to Geeta Ramsey and to Andrew Nunn. So Geeta came to see us in 98. She was doing that microbicide study at the time, and she wanted to know what we were doing in the MRC. And we were doing some microbicide work. And Andrew Nunn's one of the senior statisticians at the MRC Clinical Trials Unit. So we said to Geeta, we're doing these two studies. We were working with dextrin sulfate and Pro 2000. And I popped Charles Lacey in there because he was my co-PI of the program that came. He managed the early phase work. But these two studies, which were conducted at St Mary's and also the Institute of Tropical Medicine, looked as if there was nothing, unlike the vaccines, there's nothing you can test in the lab with these. All you can do is go to the final stage of testing and see what a difference it makes to HIV. So there's quite a preparation required in going to the final stage of testing, but eventually you get to a phase 3 study, as we call it, as I say, the final stage of testing, when you're comparing your novel product to a placebo. In this case, a placebo vaginal gel and 2 strengths of Pro 2000 vaginal gel. And DFID and MRC funded this large program. They were very generous to give us the time that we needed to do the preliminary studies to find out what the rate of HIV was, and to also understand the sociocultural context in which sex went on, and relationships were made, and the way in which women would be able to negotiate gel, whether they actually were negotiating condom use at the moment. Could we help them to negotiate condom use in general populations by providing these for free and helping them to negotiate the use? Well, I'm sorry to say we weren't able to do that in the cohort studies, but that did mean we had a population who were very eligible to take part in the phase 3 study. So Andrew and I visited all of these centres, first of all, to find out what we could on the ground. Geeta was marvellous. She took us to meet the superintendents of the primary healthcare clinics. We spoke to the nurses in the clinics. Where possible, we spoke to the women themselves, but often this was, it's different languages. That was only really possible in South Africa without an interpreter. But we slowly built up a picture. But ultimately, we had to do the studies where we enrolled women and followed them every 3 months for HIV infection. And that gave us an opportunity to do social science as well, interviews, focus group discussions, and to actually really understand what these women's lives were about. And before we went into the trial, we did a study, a fairly short study with a placebo gel, because ultimately you don't know. You see all these studies of acceptability, and people, 60% of people say, yes, I'd like it, I would use it. And then you go with the product, and in fact, no one uses it. So you don't know until you go with the product. So we went with the product. We've heard some preliminarily quite positive reports about the gel, and off we went. And this itself was a massive undertaking, so you probably can't see that at the back, but we screened nearly 16,000 women for this study, and we enrolled 9,404. Now, the main reason we couldn't enroll women was because they already had HIV, which in itself was kind of pretty shocking. But of those 9,404 women, 19 of them enrolled twice. One of them enrolled in the morning on the sugar estate and in the afternoon in the town clinic. So I don't know what that was all about. But anyway, so 19 enrolled twice. So in the end, we had 9,385 women in the study. And we had the 3 different groups. Now, something pretty exciting happened in our last year of the study. We had a kind of sister trial, and the wonderful thing about microbicides, for me and the experience I've had, has been this amazing collaboration with the other research groups who've been also doing these vaginal gel studies. And Slim and the team reported the HPTN-035 study in February of that year. They were working with 2 different gels, buffer gel and Pro 2000. And on this slide, you see the number of infections in the Pro 2000 group, 36, and in the placebo gel, far more, 51. And we like to make a little ratio out of that, and intuitively or counterintuitively, if it's less than 1, it's a good thing. So it's 0.7 here, 30% reduction in HIV infections. That's what it means, a 30% less infections, which you can frankly see with the numbers. Don't need to know the percentage, it was 30% less. Now, this was a smaller trial. It wasn't properly powered to do the final stage of testing. It was an exploratory trial. But MDP-301 was huge. It was definitely big enough. This would have been incredibly significant in MDP-301. So in February 2009, we closed out MDP-301 preparing for licensure, which in fact is a big rank up to closing a trial. We had to do, a very rapid series of monitoring visits, which Nicola oversaw. And Mary and I, who I also see in the audience, we drank a virtual glass of champagne together on the 1st of November, which was a Sunday evening, when we locked the database saying, it's all clean. It's good to go. We can give it to Angela. And we gave it to Angela. And sadly, not very long after that, she told us that, you see, remember I said it's a good thing if it's less than 1? It's really 1, basically, isn't it? Absolutely. It's what we call flat as a pancake. No benefit at all. So that's quite hard after 10 years, but it's no harder for us than it is for the women. And I absolutely commend the PIs and the teams who rolled out the result to the women. And actually, I haven't got time to go into the detail here, but I would love you to look at our site and look at some of the papers on that, because the women had benefited so much from taking part in the trial itself, from the knowledge they'd gained and the sort of empowerment it had made them feel, that in many ways, and they understood it was a trial. And that's a real credit to the teams for the informed consent, the informed consent process. Anyway, disappointing it was in December 2009, but this was less than a year later, the Caprices Study. And this study was using a very different sort of gel, because tenofovir is a drug we use to treat HIV. So it works differently. The gel we used was working in the vaginal lumen. This one's actually getting into the cells, and it's one of those stop signs that you saw on that biological slide. And women were asked to put it in 12 hours before sex, 12 hours after sex, or as soon as possible after sex, and not to use more than 2 doses in 24 hours. And the reason for the 2 doses was partly based on the mother-to-child regime, where mothers get pregnant mothers who are positive with HIV have a dose before delivery, and then the baby is dosed after delivery. So it was partly, the BAT24 was on the back of thinking of that type of regimen. And coming here, because you remember I said it's a good thing if it's less than 1, well, it's well less than 1 there. And not only that, it's all less than 1. This is the truth, where the truth lies. It's all less than 1. 39% lower confidence interval. So I happened to be privileged enough. I was on the podium with Slim and Croatia because I'd been asked to give a talk putting the results in context at Vienna when these results were given. And everybody in the room stood up and clapped them. It was an amazing moment. I've never seen that in a conference before or since. But, it was about, I think, was it 5 months later, can a pill a day prevent HIV? Yes, it can. And this was a trial that was much broader. So Caprices had only taken place in KwaZulu-Natal in South Africa. But this trial had taken place in North America, mainly South America, but also South Africa and Thailand, 11 sites. And they'd recruited nearly 2,500 gay men and transgender women to the study. And they saw a benefit with this pill a day, Truvada. And then the Partners PrEP study, that was a little later, but again, it was within the following year. This was the summer of 2011. It closed early because of the significant benefit they had seen in serodiscordant couples, all heterosexual, I think, in Kenya and Uganda. And these 2 studies formed the backbone of an application to the US Drug Authority to seek approval for Truvada to use as pre-exposure prophylaxis. And they approved it. The FDA approved it in July of last year. So this is really exciting. These are tools that are on the point of taking to implementation. But it wasn't all good news. So these are the trials that showed benefit. Here at the bottom is the benefit is 100% protection. That's 0% protection. So I'm afraid you can see down here that some of the studies using this drug, or tenofovir, a component of the drug, had actually failed to show any benefit. Now, why was that? And I think probably it's best explained with the last one that reported, the VOICE study. So this study was looking at, it was quite complicated. They had 5 groups because they had the matched placebo. They had Truvada, which combines this drug, tenofovir, and another one, and they had tenofovir in a gel. And they were asking women to take these drugs every day. They enrolled from Uganda, Zimbabwe, and South Africa. And what they showed here, remember I said less than 1 is good, so you have got less than 1 here, but certainly not less than 1 in either of these. And when you look at the p-value, which is telling you, the probability that that result is chance, it's actually 20% it could have been due to chance. So we don't accept that. It has to be 5% or less before we say that's real, that could be real. And even then, it may not be, but I'm afraid to say nothing doing there. And why not? Well, really, when they looked at the percentage of women who were in the active groups who had any drug in their sample, so sorry, this is the percentage of women who never had drug in their sample, then you'll see that half or more in each of these 3 groups never had any drug. And the average detection rate was really low. It was 30% or less. So they weren't taking the drugs, and obviously we need to understand why. Although I'm not sure I do need to understand why they didn't want to put 4 mils of vaginal gel in their vagina every day. I think I do understand that. So it did make us question the data from MDP-301. Maybe no one was using that gel in MDP-301. So this is our graph of reported gel use at the last sex act. So that's across time here. And you can see here it's just over 90%. It's 92% of women at each of the visits who came said they had used gel at the last sex act. So that's very high. And maybe you would say unbelievably high. And I wouldn't disagree. But we also collected in the applicator returns. And there was a remarkable, we had to do some estimation to get this, but that's what we call a normal distribution. And 80% agreed within plus or minus 2 applicators. Now, we also asked women, when did you last have sex? And if they hadn't had sex in the last week, we asked them to tell us about all their sex acts over the last 4 weeks. And that's quite a long time to remember. And here you see it's not quite such a normal distribution. And the difference is bigger, and it's skewed here. But it's skewed in favour of more used applicator returns than reported sex acts, not the other way around. So the applicator returns certainly suggested that women were using the gel. Now, we also defined consistent gel use. Now, to be a consistent gel user, you had to come to at least 7 visits out of the 13 visits. You had to say you'd used gel at the last sex, and you had to have returned at least 1 gel applicator. So if we say how many people managed to do that at night, are you seeing this arrow here? Oh, yes, good. Because it's flying across the screens here. It used gel at 92% of the visits. Well, overall, it's 58% of women had used it at 98%. So actually, really, 42% of women hadn't. And if you look at it for 100%, and this is very suspicious, because who manages to take 100% of their tablets? I don't know how many people in the room are taking tablets or using anything on a daily basis, but I cannot believe there'll be anybody here who put up their hand and say they take 100% of them. Exactly. So it defies belief. It defies belief. But this seems quite reasonable, 58%. And certainly, if we take the detectable drug across those studies I showed you earlier, then if you detect drug in 50% or more of your study population, that tends to go along with measuring some effect in the trial. The reason I really do believe women were using the gel in MDP-301, though, is because we had a unique design. We had integrated into the study protocol a social science subgroup who were randomly selected, up to 100 women in every centre. And we used a mixed methods to triangulate their answers to try and understand what they were telling us in terms of adherence and their sexual behaviour data. So the subgroup data sets produced from this took the clinic data, the questions asked in clinics, later on in the middle took the applicator returns as well, but these women were also asked to keep a diary record for 4 weeks before they came to their visit, and they were interviewed shortly after the clinic visit by a social scientist who's more skilled in the kind of probing interview, wasn't having to follow the very strict script that the clinic nurses were following. And not only did they interview the women, they interviewed a selection of their partners too. So what you see here in the red bars is the level of inconsistency across the reports. So perhaps not surprisingly, when you ask things in a lot of different ways, you do get inconsistency. But when the social scientists probed for the reasons of the inconsistency, it was just as likely to be, it's things like, the interviewer wasn't listening to me properly, or there were several reasons that suggested actually the woman herself was genuinely trying to record and give us the accurate data. So I do believe participants try their best to tell us, the majority of them try their best to tell us what they're doing, but we don't make it easy for them. And these are lessons that we have to learn going forward in the trials. We have to make it simpler for them to tell us what's really going. And there was confusion over some of the terms that were used, even though we'd worked that out very carefully in the beginning. So here is another example taken from an interview of a 28-year-old participant in Johannesburg. What makes you like the gel? It makes me want to have sex all the time, and I don't expect him to get tired. Well, what makes you think your partner liked the gel? He would want to have more rounds of sex with me, like 2 or 3 at least, instead of just 1 round and then fall asleep. Well, now, isn't this a marketing dream, you would think? But in itself, that's not unusual. All the trials have reported these sorts of anecdotal things. But what was impressive about MDP was the fact that these women had been randomly selected. There was a thoroughness and a formality to the way in which we collected and collated the data. And therefore, we're able to say that all women of all ages from all the centres, so they were all represented, found ways of expressing the way in which this gel gave them some sexual pleasure or increased their libido. So I've just put some of the examples up here. I'm sure I'll say this wrong, Shisa or Fisa. They used their own words, make sex hot, gave them an appetite, made it sweet. So there are numerous examples in Catherine's paper that she wrote on behalf of the social science team, which again is a great read if you look at the MDP website. And you could account for this by the eroticism from insertion of the applicator, less pain due to the lubrication, a reduced fear of bruising. Clearly, bruising and quite violent sex is quite commonplace in many of these centres, so reduced fear of that. And then because it was something that tended to lead to a dialogue with a partner about sex, which is something is not really the norm in these settings, it often led to greater intimacy with their partners too. So this is a community participation group in Tanzania. I've sat in one of these and I sat in a similar one in Zambia. And Shelley translated the Swahili for me. So when the woman stood up and she doing that, and all the women were giggling, and I said, what's she saying? What's she saying? And Shelley said, oh, she's saying when she puts the gel in, it makes her want to go and find her partner quickly and have sex. And the same thing happened in Zambia in the folks who said, and I was thinking, I don't need that to be translated. I know what that woman is saying. So I am watching this trial with great intent. We all are. The FACT-01 study is repeating the Caprices study. If it confirms the results seen in Caprices, then that can go ahead to the FDA for licensure. And this will be very exciting because there's nothing I would like more than to be working on the implementation of a vaginal gel. Still, it's not just vaginal gels. So here they are at the top here, but we've also got rings. Now these rings, which are, are already licensed for contraceptive release, okay, but they've now put antiretrovirals in them, and there are 2 trials in the field looking at these rings releasing an antiretroviral called dapivirine. If those are proven to be effective, this opens a really exciting door because it opens the possibility of combining contraception with an anti-HIV medication. Which will reduce the risk of HIV. And if you take 100 women who are sexually active and having sex without a condom, actually, in many of these settings, maybe in the worst case scenario, 8 or 9 of them in a year will get HIV. but I think it's something like 87 will be pregnant. There's no comparison between the likelihood of the two. So it does seem very likely that some women will appeal, multi-purpose product will appeal to them for contraception, and you slip the anti-HIV in there, and they may not perceive their risk of HIV. And they may not be wrong about that. 8% per year to many of you here may not feel like a big risk. To epidemiologists, that's huge. We think that's a really high risk of HIV infection. So as well as the rings, which open very exciting possibilities, we've got the pills I've already mentioned, and long-acting injectables. Now, injectables are very common in an African setting, and I think these would fit in with the healthcare norms in many African countries. So antiretrovirals are being formulated for long-acting use, and that also holds great hope, but they're at an early stage at the moment. So I want to, do my last piece here, which thank you for your patience, and thank you for most of you all looking awake. We're coming now to the last of these modalities, because I said a pill a day can prevent HIV, and in the UK, our epidemic is a pretty targeted epidemic, a pretty focused epidemic. Where is that? There it is. Okay, so this is the new diagnosis since 2000 in gay men, and you can see it's been going up and up and up and up. And now in the last 3 years, as I say, it's gone up a little bit each year, but it's been higher in the last 3 years than ever reported before. And this group we can reach because they come to our clinics. 85% of them have their HIV tests in GU clinics, and 85% of HIV diagnoses are made in GU clinics. So this group mostly are catching their HIV in UK. Over here is, I don't need to do that now, but that's basically just to show you how the AIDS has completely fallen off since antiretroviral therapy was introduced, but our new diagnoses have heaped up. So, and deaths have also gone down. So, basically the equation is that year on year, there's a larger number of people living with HIV to be cared for in the UK. It's still a small number compared to many countries, but it continues to increase. So we talk about the cascade, and the cascade for MSM in the UK is 2010, but it's very similar to the 2011 data, and I don't doubt it'll end up being similar to the 2012 data. And that is that the biggest gap that you've got is between those who have HIV in the community and those who are diagnosed. So 74% of people who have HIV actually know they have. Once people know they've got HIV, there's fantastic link to care, there's fantastic link to treatment, and the treatment is incredibly effective. You're talking about over 90% in each of those categories of people who link to care, end up on treatment, and have undetectable virus. And with undetectable virus, effectively, they're not at risk of transmission. So can a pill a day prevent HIV? And as soon as that came out, it was absolutely clear there was something we could do in the UK about our increasing epidemic. So IPREX reported, the two professional associations, the British HIV Association and the British Association of Sexual Health and HIV, recognised the need to have some sort of position statement so that staff would know what to say to their patients. In April 2011, we launched the PrEP-E group to try and bring together a range of stakeholders that we felt were necessary to say what should be in that position statement. So we definitely felt PrEP had to be integrated in a risk reduction package. We couldn't ignore all the other things that had been shown to work. But we did feel there was a need for a real-life effect. Because the key concern with PrEP across all of the stakeholders was, would people drift away from condom use or increase their partners because they believe themselves to be protected from HIV? And of course, the placebo in all of these trials is there to control behavior. So you can't answer that question in a placebo-controlled trial. So the design that we felt we needed was for gay men to have Truvada in the risk reduction package at the point of enrollment or after 12 months of follow-up. And that follow-up would involve a visit to clinic every 3 months for up to 2 years. So half of the guys would get the drug in the package for 2 years and the other half for only the second year. And we plan to do a pilot of 500 men because we wanted to know if it was actually going to be possible to do a large trial. Now, there's a few key messages here. So Truvada, in the trial in gay men, it reduces HIV. It certainly wasn't fully protective. Although if you look at the proportion, if you look at the protection in the people who had high levels of drug, it does suggest that the protection from Truvada is extremely high, if not up in the high 90%, perhaps even as good as treatment of the positive partner. It won't, however, prevent the other sexually transmitted infections. So definitely we're not targeting people who are already using condoms the vast majority of time. And it's probably still not as robust an evidence base as treatment for prevention. So if they're monogamous couples where one partner is positive, the other is negative, the better option for them is still treatment of the positive partner and undetectable virus. So that's the study website. The recruiting sites are 7 in London and 5 outside London. And the pilot outcomes are to see if a large trial is feasible. We will at least find out the level of interest in PrEP in the clinic populations and the acceptability of this randomization. If you think you're at risk, you go in, you want that tablet to reduce your risk further, then it could be unacceptable not to get it for a year. But at the moment, there is no funding for PrEP. It's not available in the clinics anyway, and the cost of implementing it in the clinics would be really quite considerable. So we will have to build an evidence base to push for the introduction of PrEP in the UK. We will learn about adherence behaviour over time, risk behaviour over time, and the uptake of behavioural interventions. Now, we've been trying to implement behavioural interventions in clinic for ages. Well, in a slightly more concerted effort for about 2 years, I would say. But it is difficult to engage people in behavioural interventions. You do have to kind of get to know them. It's not been difficult for us to engage HIV-positive individuals who we see recurrently for outpatient help in behavioural interventions, but much harder for negatives who will see a different member of staff all the time. But this is a tool of engagement where you do see people again and again, and where you are able to transition into behavioural interventions. So I think it has the fantastic possibility of engaging a group of individuals who at the moment don't really have that continuity of care in clinic. So at the moment the clinics are set up, we've got 13 clinics set up, 12 trusts, 261 were enrolled as of last Friday, and we're picking up in terms of numbers. Huge variability in the clinics. Some are ahead of target and others are less than 50%. But community participation is absolutely key in this. So Gus Cairns is a co-chair with Mike Adler of the Trial Steering Committee, and Gus works on the National AIDS Manual. We have 2 community members on the monthly call where we review progress of the trial. We have a community engagement group which has brought, as well as those organisations like GMFA and THT. We've got National AIDS Trust, MESMAC in Leeds, LGF in Manchester. So fairly good representation on the community engagement group, which Alan McCowan chairs. And then an expanded membership when we were wanting to know exactly what was going on and to have a little bit of a broader discussion, we expanded the membership to include gay media and the gay dating agencies to try and understand what was going on and why recruitment might be so slow. So overall, across the board, lack of awareness of PrEP is the feeling, that we don't think that people have actually even heard of PrEP, and perhaps that's not surprising because we don't have it in the clinics to promote directly. But also a lack of endorsement by the usual agencies. And they've come together to write a joint community statement, which was launched on Monday on all of the websites, and I'm so pleased to see that. I think that will really make a big difference in terms of acceptability. And we're moving now with 261 participants to be able to actually have participant stakeholder meetings like the one I was showing you of the ladies in Mwanza. So I'm hoping we'll be able to have some similar feedback from those meetings and from the qualitative work. So we're coming to the end now. I realised I forgot to tell you my sexual health clinic story, but I think it really is too late to tell you that now. It's a shame. But is it a shame? Do you want to hear it? I meant to tell you this when I was going to do, the lady in Johannesburg is saying that you can't be squeamish about sexual behaviour, and I'm so glad that I had my introduction to all of this in the Martha and Luke clinic, And I'd probably been working there about, I suppose it was 4 months, and I was kind of really getting into the swing of things, because it is a bit daunting when you first start. Just the fact that you're saying, to people, can you drop your trousers now, and I'm going to put this plastic swab in your penis and take and they were sort of plastic loops, or a woman, you're saying, can you put your feet up in the stirrups, and it takes a while to sort of get accustomed and comfortable with that yourself, so you're not embarrassed, and then the person's not embarrassed. But I've got into the swing of it, as I said, and we used to have the notes used to be in a box on the wall, and you'd pick the notes out, and the doctors were meant to see the new patients, and the nurses saw the follow-ups. And I picked this set of notes up, and I could see fairly quickly it was a follow-up for NSU, non-specific urethritis, as we called it in those days, and I guess we still call it now. So I should have given it to the nurses, but what caught my eye was the line below, which said LSI, last sexual intercourse in Tunisia with a camel. And I thought, right now, okay, I'm really in the swing of nerves. This is something. I'm going to go and see this guy myself. So I went down to the waiting room, and I called out his number. We never used names there, and nobody got up, and I called it again, and then this guy got up, and I don't know what I was expecting, but I wasn't expecting this chap who was about the same height as me, and it was quite slight, and it was very fair. He didn't look as if he'd come back from Tunisia, but anyway, he followed me into the room, and we sat down, and I said, have you taken the antibiotics? And he said, oh yes, I've taken them all. And I said, are you better? Because he'd come in with a discharge. I said, yes, he was better. And obviously, there's no point asking about contact tracing of the camel. But I did want to ask him, and I said, how did you, if you don't mind me asking you, I said, how did you manage to have sex with the camel? Well, I mean, the colour drained out of his face, and he nearly fell off his chair. But he said to me, does it say that in my notes? And I looked at the notes, and they were Dennis Coachman, who had beautiful, elegant writing, and I realised that what it said was last sexual intercourse in Tunisia with a casual. Well, we couldn't part company quickly enough, and I know if he's seeing this on YouTube, I apologise. But thank goodness we've moved to electronic note prescribing at 50 16th Street. This could never happen again. Oh, well, I'm glad you enjoyed that. So HIV today, gone tomorrow. Well, there's no question that the biomedical tools are there and they're coming. I mean, it's fantastic what is available to us now and what will be available, I believe, in the future. But I hope you are with me on the fact that at the end of the day, it's human behavior that is going to determine how these things work. So it's not just about behavior with condoms, it'll be behavior about the user-dependent methods that people have to, rise. We've all said no one in this audience takes a pill every day. It's user-dependent stuff. Even the vaccines, as we've seen ourselves here in the UK from the MMR problem, depend on behavior. People have to take themselves to have the vaccines, the repeat vaccines. But this is the proportion of people reporting unprotected anal intercourse in surveys over 1998 to 2008, unprotected anal intercourse in gay men surveys in the UK. And going back to the women, this is the reported condom use at the centres in MDP. So you remember that sort of slide of the gel right up there, everyone says they're using gel. Well, they certainly weren't telling us all they were using condoms. And the use of condoms in some cultures is still quite stigmatized. So some of this could have been underreporting of use, but really these levels down here of 30%, 20%, we have to use and find other tools for these women and for the men in our own community. So we worked really hard to call the PrEP study proud. It really doesn't bear much scrutiny how we managed to do this, and it was much more about gay pride. But I want to do you my little poem for the informed consent for Proud, if I could finish on that. But before I do the little poem, I have to acknowledge the wonderful people I've worked with. I've tried to show you pictures of some of my mentors. As Jonathan said, it's been an amazing journey that we've had across several continents. It's an incredible experience I'd had. I cannot believe I went to do that job as a temporary job back in '94, and I'm still there now and loving every minute of it. It's been a fantastic second career, unbelievable, and I have been privileged to work with the most amazing people. We owe, above all, to the participants who've taken part in all these studies. They're Trojan in the phase 1s, and they're noble and wonderful in the later stage of testing. And they really need us to carry on with this research. So my little poem. Informed consent in trials is actually quite complicated. So the informed consent, the information sheet that tells people about the Proud study does have a really nice flow diagram on it. It was written for us by the community, and it's incredibly easy to follow, but it is about 14 pages long. And I always try to think, there are certain things that one needs to sort of know and to get into kind of informed consent with some key messages. So, you ready? Proud is the name, proud is the game. Ain't no more reason to be ashamed. But we've got to slow that HIV from spreading through our community. Now, sex is nice, sex is good, but it's only safe when you wear a hood. So shake on out that rubber thing and pop it on your ding-a-ling. Well, that's easy said, but it's harder done, especially if you're the bottom one. But now we've got some new ways to help keep HIV at bay. Positive, negative, either way, you take your pill every day. Now, it won't stop those other things, sticky willies and sores on your bing. So positive, negative, do your best. Get down to the clinic and have those tests. And keep shaking out that rubber thing and popping it on your ding-a-ling. As proud is the name, proud is the game, ain't no more reason to feel ashamed. We will together slow HIV from spreading through our community. So thank you very much.
So much for an extraordinarily memorable inaugural lecture in every sense of the word, and I think the applause said it all. It's not standard to take questions after an inaugural lecture, and indeed all of you will be invited very shortly to a reception to celebrate directly with Sheena. So without further ado, I'd like to invite Professor Geeta Ramsey from the Medical Research Council of South Africa. It's based in Durban and KwaZulu-Natal. A very long-term collaborator, as you've heard, to give the vote of thanks. Professor Ramsey.
Good evening, everyone. I'm honored to have been asked by Sheena to give this vote of thanks for this very special occasion. Congratulations, Professor McCormick. I've known Sheena for over a decade, as she showed you the first meeting with her, sharing a passion for research on women-initiated HIV prevention options in Africa. Throughout this time, we have not only developed a professional relationship, but a bond of friendship, which I treasure dearly. Sheena's passion for HIV prevention, treatment, and care is evident from her lecture, and her approach to both scientific and personal issues is reflected in her bright and cheerful personality. We all notice that, right? Sheena has a unique ability to make the most disheartening moments tolerable. I remember a meeting in Uganda where we received the results of the MDP 301 trial. As the principal investigator of the study, the onus was on Sheena to present the disappointing outcomes. As expected, all the teams were devastated, and although she herself felt the same, she was consoling and counseling everyone and giving out positive messages regarding the execution of the trial and how everybody made a difference to the lives of the women participants. That night, she danced the night away with the young African investigators, while most of the senior investigators sat wondering, where does she get the energy? How does she do it? And I'm sure that many of you know who know Sheena wonder about that all the time, every day. I've had the unique opportunity to watch up close how Professor McCormick approaches problems, and I'm sure you got a sense of it from the lecture tonight. For someone residing in the UK, she completely understands the plight of women in Africa. In the context of both social and cultural sensitivities, including the diversity in human behavior, she approaches issues with a dedication of scientific honesty and precision. She is compassionate and is dedicated not only to HIV prevention, but the need for treatment and care for those who are already HIV positive. I have conducted many clinical trials with numerous investigators around the world, but Sheena stands out as one person who truly understands the complexity of human behavior and the socioeconomic and the cultural vulnerabilities of the study subjects. Due to her extensive experience and understanding of clinical research, she is highly sought after and is a member of numerous advisory and monitoring committees. As mentioned in Professor McCormack's talk, after years of working in HIV prevention field and a number of disappointing results, we now have products that can be specifically targeted to key populations such as gay men and discordant couples. We also witnessed the proof of concept for the microbicides with the CAP004 trial, with confirmation trials ongoing. The challenge now is to how best to deliver these successes in a way that people who need them are likely to use them. Well, Professor McCormick is in a unique and exciting position to not only conduct intervention trials as a highly skilled researcher, but help find ways to deliver successful products to people who need them through her clinical work. There are very few investigators who are able to link product development research into clinical practice and implementation science. Her current passion in the product development continuum from efficacy to delivery in the real world setting is realized through the PROUD study. Professor McCormack, Sheena, you have been a sometime collaborator, but a longtime friend and a confidant. You supported me through those disappointing results, and collectively we have emerged stronger, as the recent successes and lessons learned have paved the way for exciting times ahead for HIV-related public health research. I look forward to collaborating on new projects and testing interventions that have been shown to be efficacious. Your lecture tonight touched on a series of important and fundamental advances in one of the worst epidemics in the world, HIV and AIDS. On behalf of everyone tonight and in attendance this evening, I thank you for your lecture, the insights that it has brought us, and wish you happiness and success in all you do in the years to come. And please remain exactly how you are, bright and cheerful and very funny. Thank you.